Okay, so today we're going to talk about the low back assessment. Okay, so here's an outline of what we're going to do today. We're going to talk about low back applications, the live assessment, the report, adding pain, and a guide to alerts. We're going to talk about the low back monitoring session and how to use that and apply it clinically. We're also going to talk about live training, which is an excellent kind of neuromuscular re-education tool. We'll talk about biofeedback, and we're going to go into the RCT, the randomized controlled trial that we did, that gives us the ability to talk about our low back assessment in terms of treatments and outcomes, because we've proven that there's an improvement in both function and pain. And then we have a case. Okay, just a few terms. So sometimes people get this confused initially, but live assessment is when we're collecting baseline data for the low back, and it's always referring to a test where the RFD is attached to the surface. Monitoring, on the other hand, is when the RFD goes with the subject. So we have a monitoring application for low back, so you can send the subject out to work and throughout their day to monitor their positioning throughout the day. And we also have one for running, so when people can go run over ground. So the applications for the lower spine. The first one is the live assessment. The second one is monitoring. We're going to go through all these in detail. The third one is live training. The fourth one is tailored biofeedback. So first, live assessment. I just want to look at data lines for just a second to kind of orient everyone to seeing, having an idea of what you're looking at when you're watching the screen. When you first get a dorsaVi system, if you're not somebody who's been in a motion capture lab, these just look like a bunch of squiggly lines on the screen. So it's a good idea to kind of study them and get an idea of what you're looking at. So in this case, this is the zero line is baseline down here at the bottom. And then we have the gray line, that's the biggest arc, and that is the movement of the top sensor, or the sensor that's at the TL junction. The red line is the movement of the sacral sensor, or the pelvic sensor, that's at S2. And then the black line is the difference between those two, and that's lumbar spine motion. So if you bend forward and your top sensor goes through 105 degrees of motion from start to finish, and your bottom sensor goes through 60, the difference between those two is the lumbar spine range of motion, which in this case is 49 degrees, and that's the black line. The green line is EMG activity. So this is showing a pretty normal case of EMG activity. We typically see when people start the motion to bend forward, they get a little spike, and this is bilateral EMG activity. And then when you come up to stand, you get a bigger spike. Okay, I want to dive in and go right into looking at the lumbar live assessment report. So the first page, we have the summary of their movement. This is, I used my example. So I'm an ex-gymnast. This is a little weird, a little bit more extension than you would normally see, but we call it the egg because normally there's a bunch of flexion, a little bit of extension, and then equal amounts of side bending, and it looks like an egg. One thing that I want to point out with numbers and looking at data is in our system, flexion is always positive, as well as any movement to the right. So in this case, flexion and right lateral flexion, or right side bending, are positive numbers, and extension and left are always negative. So in this case, we have 44 degrees of extension, that's a negative number, and 16 degrees of left lateral flexion, that's also a negative number. This is just good to know when you're looking at all these numbers on the screen and on your report. So the next part of the report shows you the lumbar lordosis. So as soon as you put the sensors on the subject, and it has you calibrate their lumbar lordosis, so we have a starting position. And just to orient you to this screen, we have top left, it says lumbar lordosis, and then you have the patient's lumbar lordosis. And in the top right, you have the reference values. This is normative data that we collected that is age stratified. So if you put a birth date in for them, which you have to, you're going to get what they are compared to all the folks born in their decade. So in this case, normal lordosis is 29 degrees of extension. You'll see this is a negative number because extension is negative. So the norm is 29 degrees, and again, this is my report, and I had 52 degrees of lumbar lordosis, which is too much. And so in addition to giving you the actual curve between the two sensors, so that's the positional information of where the person is standing, their sacral sensor versus their trunk sensor, and the difference between the two is their lumbar lordosis. It also gives you each of the sensor's positional locations. So trunk is the upper sensor that's at TL junction, and that in the normative reference values is at -11. So it's at 11 degrees of extension. And the pelvis, or the sacral sensor, is at 18 degrees of flexion or nutation in the norms. And then if you look over here at this, which is my report, my pelvic sensor is at 31 degrees of flexion or nutation, and my trunk sensor is at 21 degrees of extension. So if you take that 21 degrees of extension in the negative direction all the way over to 31 degrees of flexion, you're going to get this 52 degrees. So -21 plus 31 is 52. So that is the difference between the position of those two sensors. And then we have an alert. Yes, this is true. This is a high lumbar lordosis. So we have a guide to alerts, which I've given you the link to at the end of this presentation. And you guys should all have that. And you can also find it on your Dropbox that has your marketing materials, but I can send it as well. And I probably will when I send out these slides to you afterwards. So we also have a comparison to past sessions over here on the right underneath the reference values. And you can see that there's a date and a green dot that shows lumbar lordosis as I move along. So it's showing you over time and how the lumbar lordosis is changing or not. And then it also gives you where that person stands within the population. So the mean is 29. I'm way out here. And in fact, it's 52, and so it's off the charts. So it should be even farther over to the left. So that's lumbar lordosis. So lumbar flexion is the same setup for reporting, and we'll go through this just so we can really get grounded on what we're looking at here. So the reference values say that normal lumbar lordosis in my age group is 48 degrees, or I'm sorry, lumbar flexion is 48 degrees. I had 63 degrees of lumbar flexion. You can see that in the normative population, the trunk sensor tends to go through an average of 108 degrees of space from start to end. And the pelvic sensor goes through 61 degrees. So if you take 108, it's 48. In this case, in my case, my trunk sensor, the top sensor, went through 146 degrees of flexion of space, and my pelvic sensor went 7 degrees of space. So they both moved a lot, and you take 146 minus 87, get 63. What's really interesting about this, and which is just so great if you look at this and apply it clinically, is it's giving us an alert that says I have a poor restricted lumbar to pelvic ratio, which means that I am moving mostly from my hips, so I have extremely flexible hamstrings, so a lot of my motion comes from my hips, and you can see that my pelvic sensor moved more than 20 degrees more than the norm through space. So you can see where they're getting their motion by looking at where the pelvic and the trunk sensors are moving and positioned. And again, you have comparison to past sessions underneath the reference values at the top right, and you can look at how the subject's changing over time. And then down here on the bottom right, I wanted you to look at the legend. So I have here over at the right that the gray line represents the top sensor, or the thoracic lumbar junction sensor. The yellow line represents the sacral sensor, or the pelvic sensor. The black line is the difference between the two, which is lumbar range of motion. And the green line is the EMG activity. It's also listed here in the bottom right of your report. So it's really helpful to look at the pattern. So you can kind of just dumb it down by saying you want the lines to go gray, yellow, black as you're looking down when they're bending forward. And then you can look at the patient's reference pattern on the bottom left and see if it follows that pattern. So in this case, it does follow the correct pattern. Sometimes what you'll see is that somebody's yellow line, or the pelvic sensor motion, drops below the lumbar spine motion, or the black line. And then you know that that sacrum stopped moving at some point and all the rest of their motion came from their lumbar spine. And in this case, you can see that it's at rep 2 where I just moved, my sacral sensor moved a ton especially, and we get this big discrepancy between the black line and the yellow line, whereas in the reference pattern, they're closer together. Joanna, you have anything to add to that?
No, that's perfect. Perfect.
Okay. So here's extension. And again, we have the same setup. The reference values say that lumbar extension should be around 18 degrees. Of course, I'm stupidly hypermobile and I have 44 degrees of lumbar extension. When I moved into extension, my trunk sensor went in through 40 degrees of space. The pelvic sensor went through 3 degrees of space, or well, into -3, which is it extended 3 degrees, and so the difference between that is 44. And you can see that in the reference values, the pelvic should move into -12. So I was getting a lot of my motion from my lumbar spine because my pelvis really didn't move that much. So we can see that it's confirmed down here at the bottom left. So in the middle at the bottom, you see the reference data, and it should be, you know, minimal EMG activity, which is something to note. That green line is pretty flatlined, and then as you go down, you'll get the yellow line, which is the movement of the pelvic sensor. The black line is the difference between the pelvic and the trunk sensors, and the gray line is the trunk sensor movement. Now, this is such a crazy example because you can see if you look at the yellow line in the patient's pattern at the bottom left here, my sacrum is not doing much, and then it actually goes above the line into positive. So it's actually going into nutation instead of extending like the reference pattern where it should extend downward. So that's why you have the gray and black lines right on top of each other. So the black line representing lumbar spine motion and the gray representing the movement of the top sensor, they're right in line with each other. So that tells me that all of my motion into extension is coming from my lumbar spine and nothing coming from my pelvis or hips. And lumbar spine even dips down more, and that's because you can see if you look at the yellow line and it goes above into the positive, that makes the discrepancies between the yellow line and the gray line even further. That gives me that little extra excessive lumbar spine motion. Crazy. Good thing I don't do gymnastics anymore. Okay, lateral flexion. So similarly, we see at the top, you're going to see left lateral flexion on the left, right lateral flexion on the right. I had 16 degrees. It's negative because it's left. And then 14 degrees on the right. It's positive. And then the reference values are underneath there, right in the middle. And I have a little bit of a restriction. So the normative values are 22 and 23 degrees, plus or minus 6 and plus or minus 5 standard deviation for side bending. And then you have the patterns down here. Another thing that I want to say about this patterning is when you look at these lines on the report, if somebody has pain or neuromuscular control issues, you'll not see a smooth line here. So you can see that happening over here, the right movement pattern, patient's pattern, the yellow line, there's this jitteriness. That might be a little bit of some neuromuscular control issues or pain, and it shows up that way on the report. Okay, pelvic tilt in standing is next on the list in the report. And you can see here we start with posterior pelvic tilt. Now, posterior pelvic tilting puts your lumbar spine in position of flexion, correct? But we have extension here. You see it's a negative number, -17. The reason is because this refers only to the pelvic sensor. It's not telling you about lumbar spine position or motion. It's looking at the pelvic sensor. So when the pelvic sensor starts in a position of nutation or flexion, that's positive. And then you move backwards into posterior pelvic tilt, that is extension of the sacrum or counternutation of the sacrum, so it's a negative number. Did I explain that well enough, Joanna?
That's good. Yep, it's all good.
Okay. Yeah, so that, I just want you guys to make, I want you guys to have this so that you can look back and go, wait, posterior pelvic tilt's flexion, well, it's referring to the pelvic sensor only, and that's why it's extension. And then if you look down at the bottom, you have this really great kind of bar graph that shows you where my standing pelvic posture is, and that's they call it the 0 point, my lumbar lordosis, wherever my pelvic sensor was there, and shows you how far I can go to the left into posterior pelvic tilt, which is 17 degrees, and then I can go anterior pelvic tilt into 13 degrees. So where this is helpful is you'll have some people where their blue bar, their standing pelvic posture, their neutral, is way over in the posterior pelvic tilt, and then you know that they're hanging out at clearly almost the end range of their posterior when they're in stand. So that gives you some good information. Similarly, you might have a gymnast whose blue bar here is way over close to their end range anterior tilt, or not even a gymnast, just somebody with a lot of lumbar lordosis, and then you know that they're hanging out of the end range of those structures in the anterior position, and that's going to give you some good information off of which to make some clinical decisions about how you're going to intervene, and information on why they might be having pain. So underneath there you see that my total pelvic tilt range of motion was 30 degrees, and underneath that in the gray at the very bottom is the reference pelvic tilt range of motion, which is -8 to +15, so I just have a little bit more posterior pelvic tilt than the norms. The next piece shows you the pelvic sitting position. So in the lumbar spine, if there's some of you on that don't typically do this test, we take a 5-minute static positioning 3 different ways sitting. So we tell the subject, please sit in your usual position, and we monitor what that is for 5 seconds. Then we say, please slouch, monitor for 5 seconds, and then please sit upright like you're trying to sit, like your grandma's yelling at you in an upright position. So on this bar graph, we have, if you look at the very right, active anterior tilt range of motion. So in sitting, I was able to put my sacrum into a +2 degrees of anterior tilt. And if you go to the very left side, you see active posterior pelvic tilt. So I was able to posterior pelvic tilt my sacrum, extend my sacrum 36 degrees. And then if you move just to the right of that gray bar, you'll see slouched pelvic position. So when we monitored me in slouch, I was in 35 degrees. So when I slouched, I'm almost at the end range of my active posterior pelvic tilt ability in sit. And then you move on to usual pelvic position, 24 degrees of sacral counternutation or extension. And then upright pelvic position, I moved into 12 degrees. I'm still not at 0. So this is kind of a normal pattern. This is how you should see it. The active anterior tilt and the active posterior tilt should be the bookends. So that should be their range. And then slouched, usual, and upright are according to that. However, if you've done this test a lot, you've probably realized that some people just don't understand how to find anterior and posterior pelvic tilt. That means there's some other work to be done, right? They're not really understanding that. And so you'll sometimes see that the active posterior pelvic tilt is less than their slouched position. So that's actually really good information as well. That means that they don't know how to find actively on purpose their posterior pelvic tilt and range, but they sit like that. And then at the bottom you have, so the pelvic tilt range of motion was 38 degrees total from end to end in sit. And then you have the reference values, which is about 37. So it's kind of right on target with the normative values. Okay, Joanna, anything to add about that report before we move on to monitoring?
No, I don't think I have anything to add. That was excellent.
Okay, good. So now low back monitoring. This is where you can put the sensors on the patient and you take the RFD off, and it goes with them because the RFD has to be within 10 meters of the sensors in order to record the information. And it can monitor all of their activity throughout the day for up to 24 hours. And there is a report that's generated. So the monitoring gives you really, really good information, and it's all about increasing awareness in your patients, right? So I always say that 80% of getting better is your awareness, probably even more, right? So if you're not aware that you're slouching all day, or you're not aware that you're unloading your right leg all day and downberging and sitting in the left side bending all day, and you wonder why you have left radiculopathy, you can't change it until you're aware of it. So this is a hugely important, useful tool for helping increase awareness both for you and your client to help them make a change, and obviously to direct your clinical interventions. All right, so of the monitoring report, the first page is summary page. So it shows you at the top right how many hours they monitored. So it's 2.6 hours, and it gives you the time. And then it gives you an orientation summary. So they spent 20% of that time standing, 62% of that time sitting, 13% of that time laying down, and 5% of that time in dynamic movement, just moving around. So actually, this is in the wrong spot. I'm sorry, this slide's in the wrong spot. This is supposed to be during the live assessment, but it's a good one to know. And again, I apologize, but during the live assessment, you can record pain. So while they're going, if they have pain, you just have them tell you the number, and you just click that number on your keyboard, and it'll record pain. And if you look down underneath, the little guy that's flexing says flexion, and you see pain alert recorded comparison, it says pain level 4. So yeah, sorry about that. It was a little out of order, but you can record pain during the live assessment. Really, I think that's underutilized, so keep that in mind. Okay, now back where we were. I'm going to get some grief about that, I just know it. Okay, so standing in the monitoring session. So this is where you sent them off. It was 2.6 hours they monitored this person. And so let's go through this, kind of piece it out. This is max range of motion. So during that monitoring session, in flexion, it shows you how far they flexed during the monitoring session compared to their live assessment. So obviously you have to do a live assessment before you do a monitoring session to gather the baseline data. So in their live assessment, when they did flexion, they flexed to 61 degrees. During that monitoring session, their max degree of flexion was 57. So they almost went to their max flexion just during their activities during that session. And then it also gives you the position of the lumbar, the trunk sensor and the sacral sensor as well, so you can compare that to their live assessment data compared to what they're actually doing in life. Okay, so same thing for extension. During their live assessment, they had 30 degrees of extension when actively extending. During the monitoring session, they didn't use quite all that. Their max extension was about half. And again, trunk and pelvic sensor position information. Same thing with lateral flexion, both ways. This one I really like. So underneath that, on this same page, you can see your positional tendency throughout that time. So this first bit has extension and flexion, the zero line being neutral. The mean of the normative mean is about 6 degrees of flexion in standing. And this person, this gray shaded area, indicates that they spent the majority of their time in this region, which is between about 6 and 15 degrees, 6 and 13 degrees of flexion. It's where they kind of tended to hang out during that time. Similarly with lateral flexion. So the mean is here, and they tended to be just a little bit in left lateral flexion during that time while they were in standing. So the system knows when you're in standing because it has that baseline data, and it can tell you where you tend to position yourself during that time. So for me, when I did my own monitoring session, I have, not only do I have kind of a longer left leg, which puts me into a little bit of left side bending, but I also have a really bad right knee, so I tend to unload that knee. And as aware as I am, and I try not to do that, my gray little shadowed area was in about between 5 and 10 degrees of left lateral flexion for the monitoring session that I did for a full day. So that was really telling for me. I actually didn't realize that. So as a therapist and someone who looks at this kind of stuff and is super aware, and like a, an ex-gymnast, you think I'd be huge, really body aware. I spent that monitoring session was an eye-opener for me. So you can imagine what it would be like for patients who really aren't paying attention. Awesome information. So here's standing continued. So what this shows you is sustained flexion events and all flexion events, and same with extension. So if you look over the bar graph, short term is less than 30 seconds. Sustained would be more than 30 seconds, holding one position. So they don't have any blue bars, so that means they didn't hold any position greater than 30 seconds, but they did hold short term, so less than 30 seconds, 3 reps. They did that less than 30 seconds between 20 and 40 degrees of flexion, and there were 3 occasions that they held a sustained flexion for less than 30 seconds in a position of 40 to 60 degrees of flexion. And they didn't go past 60 degrees for any period of time. So this is important. So if somebody goes out and does a monitoring session and you see that they have 5 events where they sustained 60 degrees or more of flexion, this is telling, right? Or even 2 events of sustaining that for greater than 30 seconds. And then over here on the left, all flexion events tells you they had 2 flexion events per hour and a total of 6 during the time that they were monitored. This is also really good information because people do not realize how much they move into flexion. And then extension, of course, is less. They had an average of 0 per hour and only 1 over the whole time that they were being monitored. And then that 1 rep of extension was less than 15 seconds, and it was between 10 and 15 degrees of extension. Okay, sitting. So here's sitting posture, and it's telling you that of the time they sat during that session, 88% of it was slouched, 2% was upright, and 10% was usual sitting. Now this was the eye-opener for me as well. I did this for myself, and I spent 80% of the day sitting. Now mind you, it was a Sunday, and the Broncos were playing, so, but I also, percent of my sitting was slouched. That was really interesting, and I wasn't trying to play with the system. I was just doing my thing. So this is telling. And then the same kind of gray positioning tendency for sitting. And this also shows you see over here on the right, it gives you the red-orange line that shows your usual sitting position. The blue line is your upright position, and the slouched is your the purple. And so you can see that they tended to sit in even more. Their gray line is even to the right of the purple. So their slouched position when we tested them was 26 degrees, but they tended to be here, 33 degrees of flexion in their sitting position. So the test was not actually their actual sitting position. Hugely telling. All right, so static posture summary. This gives you the total number of uninterrupted posture periods. So while they were standing, there were none. That means that they were kind of moving around. While they were sitting, they had 2 episodes where they sat for 10 to 30 minutes, and 1 episode where they sat for 30 to 60 minutes. Episodes where they sat longer than 60 minutes. So this is really good information for those folks who don't realize how much they're sitting. And then it tells you the same thing, how much of that was slouched. So 4 episodes of sitting for 10 to 30 minutes in a slouched position. And then the final graphic it gives you is the longest uninterrupted posture period. So while they were standing, the longest they stood without moving was 6 minutes. While they were sitting, the longest they sat without moving was 38 minutes. And while they were slouched sitting, The longest they did without moving was 18 minutes. Okay. Anything to add with that, Joanna?
No, I don't think so. That was great.
Okay. So the next one is live training. So live training is part of the lumbar spine. Now you guys might know that we have movement challenges. That's another module separate from lumbar spine, but live training is within the low back assessment itself. I'm going to play this video, and please, Joanna, let me know if you guys cannot hear it.
I cannot hear it.
Okay,
But I
well,
think
I
it's
was
okay. You
afraid of
can
that.
talk through it. It's fine.
Okay, except for I can hear it, so I'm gonna.
Oh, do you want me to talk through
Okay,
it? Because I can't
yeah,
hear it.
yeah, go ahead.
Okay, so what you can see here is obviously she has the sensors on, including the EMG sensors, and the patient is watching the balls on the screen. You can see up on the screen to the left are some balls that are depicting the sensors and also the low back movement. They'll come into play in a second. On the right side of the screen is the actual data lines, but usually I just have the patient focus on the actual balls. So, and you can see that the balls are moving, and you can also see maybe in the bottom here it just shows you which ball is which. So and you have the ability to actually click off these balls and just look at whichever ones you want. So the red and yellow is the pelvic sensor, and then the blue is
Oh,
the,
sorry.
that's all right. The blue is the trunk sensor, and then the red and black is the actual lumbar spine. So this is the perfect example of those patients who you can never teach how to do a pelvic tilt. It takes you forever, just, manual instructions or hands or verbal instructions. You put the sensors on, you tell them, take the balls apart, take the balls together, and within 2 seconds, they're pelvic tilting. I always describe it a bit as like the lumbar Wii. It's like kind of like that immediate feedback. So
Yeah, it just improves the learning so just exponentially. Okay, so that's the basic use you can do it. You can do it in standing, you can do it in quadruped, you can do it on the ball like they showed in there. It's really, there's endless applications because it's just raw data and live time, real-time information. So we've had clients who have used it for golf swing corrections. So if you remember the grid, it has a vertical and horizontal line. Well, the vertical line is flexion extension, so it's sagittal plane. The horizontal line is side bending. And so if you have somebody who tends to be extending in their golf swing at a point where they shouldn't be, you can have this screen in front of them on the ground or put it up on a chair and say, I want you to keep those balls on that horizontal line, because if they move into extension, it's going to go down, right, in the sagittal plane. And so they can practice just watching the balls and doing their golf swing and keeping their lumbar spine from extending or flexing. Same thing with a batting swing. So Joanna, tell us a little bit about how you used it with that.
yeah, so we have one clinic that does a lot of treats a lot of baseball players, and they have a guy who's a hitting coach who came in, and so he wanted to see if we could use it for that. Now, I'm not a baseball expert, obviously, but what he said that the kids' issue were that they would get into the hitting stance position the first time, then they'd swing, and they'd have the inability to get back into that same position again. I liken it to a tennis serve where you've really got to weight that back foot and sit your butt down and get back there. So what we actually did was we went into the live training and we took them into their hitting stance and made that their neutral. So that then became the neutral. So each time they swung, now the next time they'd have to bring the balls back exactly to the neutral again, and put the lumbar spine right in the crosshairs there. So, and then you could just do it as a ongoing visual reminder. So I love the live training because I think you can use it for mobility issues, you can use it for stability. You can either move the balls or keep the balls still. So if you just think about all the different applications.
Yeah, so essentially for a stability example is I still see patients once a week, and so I'll use it for an RDL. So I came into this clinic and sometimes the tech was taking people through exercises and I was kind of cringing. So I'll run over and put the sensors on and say, okay, now I want you to keep those balls right where they are. I want you to do a single leg deadlift and keep those balls right in the center because they were just flexing from their lumbar spine instead of hinging on their hip. So they just learn so much faster. It's super effective. And you can use it in the clinic and say, okay, practice, and leave them to practice while you go do other things. You can multitask. So that was live training. Biofeedback is the next application that I wanted to talk about. And this is where you're actually going to send the RFD with the client, just like the monitoring session, but you're going to set parameters before they go. So let's say you don't want them to move out more than 40% of their max flexion throughout the day. You go in and you pick to the left here. You can see all the different options. So standing range of motion, sitting range of motion, flexion range of motion, extension, and you can say, I want them to get an alert if they move more than 40 degrees or whatever it is you choose. And down here at the bottom left, you can see you can choose the percent of motion that you want the alert to occur at. And then over at the bottom right, you can tell it how often you want that to happen. Once every 10 minutes, once every 5 minutes. So if you don't want them to sit longer than 5 minutes, then you can set that accordingly, and the RFD will buzz and beep and remind them. So this goes back to that awareness, right? So you do the lumbar live assessment and you see their baseline, and then you can do a monitoring session and you can see, wow, look how much you're sitting, or look how much you're sitting and slouched, or look how much you're side bending to the right during your day constantly. This explains why we're having the symptoms you're having. And then you can send them through biofeedback. So they've got those first two things, and then move into the biofeedback, and it just increases awareness all that much more. So that's where I wanted to kind of transition into talking about the randomized control trial that we did, because we used biofeedback in that study. Joanna's going to take over from here. So Joanna, you can just, I'll tap
Flick for
whenever.
me. Okay. So this
Yep.
was a randomized control trial that we published earlier this year, and I'll give you the title, and if you want the actual whole article, we actually have a link to it, but it was done in Australia, and it was the effect of changing movement and posture using motion sensor biofeedback versus guidelines-based care, looking at the clinical outcomes of people with subacute or chronic low back pain. And it was a multi-center, cluster randomized, placebo-controlled pilot trial. So what they did, the goal was the hypothesis that they had was that modifying patterns of your painful lumbopelvic movement using the sensors in people with low back pain would result in reduced pain and activity limitations compared with a control group, in inverted commas, who just had guidelines-based care. Now, guidelines-based care was that you would treat them within the normal guidelines of the treatment of low back pain. They did not mandate what the treatment was, obviously. And there was also some goal on to doing a larger study at some time. Okay, next. So the inclusion criteria, which is really pretty standard for any low back study, was that they had a primary complaint of low back pain or back-related leg pain. They were between 18 and 65. They had to have at least a 3 out of 10 on a pain scale, and they were either subacute, 3 to 12 weeks, or chronic, more than 12 weeks. And actually, the vast majority of these people were more than 12 weeks. Now, the nice thing about this, for those of you who are in regular clinical outpatient practice, that looks like your regular patient population. So it's not in some group that we wouldn't normally see. Obviously, they excluded people who'd had surgery, pregnant, all those other things that we would normally exclude for. So what they did, they actually had 8 centers. So it was a multi-center trial, and they randomized the patients. They had 112 patients divided 58 to 54. And so they had one on the right, they had the guidelines-based care. So 4 centers did guidelines-based care. In other words, they just did regular physical therapy. And then the other group actually had were using the V-Move system. Now, and they had 58 people in that one. So they did that group, they had 6 to 8 treatments over 10 weeks, and then they followed them at 3 months, 6 months, and 12 months. And the other group had the same. And so one of the things that we really wanted to look at too was and one of the things I really wanted to show with this study is how you use the system in your regular outpatient practice and how well these results were. So the first thing that the groups did, or the V-Move group did, they did a live assessment and they did a monitoring session. And the goal of the live assessment and the monitoring session was to determine how they were going to treat them using the technology. So they had to identify one of these 4 things, or it could be more than one. So were they having excessive end range postural positions like we just talked about in the monitoring report? Was that happening? Were they repeatedly at the end range of the movement? Did they have reduced muscle activation and or weakness? They used EMG with the monitoring, or did they have overactivation of the muscles? So having determined all of that, then they would determine how they were going to treat them using the V-Move. So the subjects that were in the V-Move study, or the dorsaVi, using the actual system, they could decide how they treated them, but it included obviously live training in the clinic, V-Move biofeedback. So each of the patients had biofeedback on for 4 to 10 hours. So they kept the sensors on for 4 to 10 hours after their treatment session. They were also given specific exercises, and those were seen for 6 to 8 treatments. Now, both groups had the sensors put on them after treatment. But one group obviously had the biofeedback set. The others just had they were sensors, but they were sort of sham sensors because there was nothing, no limitations put onto them. And in addition, they also received advice on, usual management of low back pain, and everybody had 4 to 10 hours of this. And you can see how often they were seen and when the follow-ups were and how many treatments that were given. So we did outcome measures and Roland Morris Disability Questionnaire, the patient-specific functional scale, and the visual analog scale as well. They also did some secondary outcomes of daily pain score, low back pain, analgesic use, number of pain-free and medication-free days, and then recurrence. What was also very interesting, which came out in the research as well, that actually the analgesia use in those in the V-Move group was significantly less as well. So looking at the results, first on pain, so just purely on their visual analog scale, the V-Move patients, so the ones that actually received the sensor treatment and using biofeedback or live training, 3.3 times more likely to have clinically important improvements versus standard care at 12 months. So the blue line is the kind of control group just receiving regular care, and the black line is the movement biofeedback group. And this was, you can see that where their pain scores actually went even further down than they were at 26 weeks. So the nice thing about this study is they maintained the improvement at a year. So, a lot of studies show great improvement early but don't necessarily maintain it. But actually by changing someone's movement patterns, you can decrease their pain and sustain that for a year. So
yeah, and I'll just add that goes back to that awareness bit, right? So
right.
we've made by doing this and increasing their awareness and kind of putting the locus of control back on the patient, I think that makes more sustainable outcomes.
Yes, absolutely. And then you can see that previous slide was obviously their pain score. Now we have that function based on the Roland Morris and the PSFS. So you can see that in both of these, looking again at the V-Move patients and the regular control group, 2.4 times more likely to have clinically important improvements versus standard care at 12 months. And on the patient's functional, 2.5 times. So maintaining those improvements and actually completely probably due to the fact that you actually change someone's pattern of lumbosacral movement and or posture. So the nice thing is that they were treatment effects were moderate to large at 10 weeks and then sustained at 12 months. And I wanted to show this because I think it's important that you can see how you can integrate this into your treatment of your low back pain patients, because sometimes people are like, well, where do we start? Start with a live assessment, potentially monitoring, but also use monitoring with the biofeedback and the live training, and you can see the results that you will have. And then Peter Kent came out with the studies at the conclusion that the results are unusual and encouraging because they show moderate to large effects at the end of 10 weeks and then ongoing through 12 months. We actually have a study, Wake Forest University is actually doing some research with us on adolescent idiopathic scoliosis. And one of the professors there, the reason he came to us is because he read this study. And as soon as he read the study, he wrote to us and said, I think you guys just cured back pain. Now, that would be a lovely thing, of course, and an absolute miracle. But, if you look at the way this study was done and what we can do, and even if you think about the way you can modify that into your practice by changing postural awareness and movement patterns, you're going to have amazing results.
Yeah.
All right, Shauna.
Awesome. Yeah, thanks, Joe. That was great. So I've just added for you guys, this is the link. So I'm going to send out the slides. So you'll have the link to the RCT so you can read it yourself. Okay, so let's go on to the case example. So this just came to me. I haven't had a whole lot of time to study it, but it's an interesting one. And Renuka, are you still on?
Yeah, I'm still here.
Oh, excellent. So I'll just explain this real quick, what we're looking at, and then you can talk about how I would love it if you could talk about how you applied this clinically. So we're looking at this guy's egg, which doesn't resemble an egg very much at all, because you can see that he has 33 degrees of lumbar flexion. He has no lumbar extension, and 18 degrees of right lateral flexion and 14 degrees of left. And then do you want to, I just totally copied this from what Renuka showed me, that he's a 57-year-old guy who runs greater than 5 miles a week. He works out, and muscle, I assume means he's really muscular. He's unable to sit at work or sleep. His MRI is clean. And Renuka, tell me why you think this dorsaVi results explains his agony.
So here's the thing. This gentleman I've treated over the last 2 years, he's always come to me with hip tightness, and he loves squatting like 180 pounds, 160 pounds, and he keeps saying, oh, my hips hurt, I know I'm tight. And he came in again this time, and I was like, what's happened? He's like, I have this back pain, and he says, I bought 5 ergonomic chairs. They're not working for me, but I can't sleep. And he says, why don't you come to my office to hook me up so that you can tell me how I'm sitting badly? And I said, look, there's no point shooting in the dark. Why don't we do this test where we can actually see where you lack? Because if you've already spent 1,500 to 1,800 on a Herman Miller chair, you've got the chair, but you can't use it. So we did this dorsaVi thing, and honestly, when I saw his resting lumbar lordosis at -5, I'd never seen that before. And so I took out everything and I restarted the test because I had never seen this in my life. Such a low curve measure, and I've been using the system for a whole year. And so we re-put it on, and again, we got the same curve. And then the more I did the test, the more I realized what was happening. So this is someone who's like a football player, stocky person. And so we looked at his lumbar curve, and he's got this hyperactivity of his muscles, hyperactivity of everything. And you can see how he moves. He's just, like you wanted those lines to be gray, yellow, and he doesn't really resemble the curve correctly, but he's very, he has, each curve is different. Sometimes he holds the motion, but if you put standard deviation, and he doesn't look so bad in flexion, he can move. It's not so bad. But when you come to extension, it's, yeah, it's even more scary. And so I was like, And the thing is, when you see those graphs looking so jagged, you think, what is his muscle activity like? I mean, he's already in a high resting tone and he's just going compressing and compressing into it. And this was not, he cannot really go into extension, this person. And he's there and then he's there. And so
Yeah,
nothing
so if
happening.
I
And if you
could,
actually see his video, you'll see him swaying a lot in the video. And this is why I love this, the way the dorsaVi was measuring it. Because if you look at his video, you'll see him going backwards, but it's all happening at his ankle joint and his knees are getting flexed. And so
yeah.
people think he's in extension and he's not. And imagine this person doing bench or, doing a squat and doing any overhead motion thinking that this is fine. So then we did his side bend, which wasn't, it was fine, just really stiff.
I don't
Um,
think I put that on here, sorry.
that's okay. Just go to the next one. Do you have his sitting?
I don't, but I'll find it. Hold on a second.
So anyway,
Yeah,
yeah,
here's his sitting.
yeah, perfect.
Let's see.
Yeah, and so this is what, what Shauna was saying earlier, that you're supposed to have the two grays on either side, but you can see that his slouch sitting is way past his posterior till he's sitting at maximum slouched. Where are his grays? So he doesn't have grays, he's got blues. Shauna, your report has gray boxes.
Yeah, it was just different colors.
Yeah. So anyway, you can see that he doesn't have a lot of pelvic motion even in sitting. And usually what I see in people in sitting have more pelvic motion than in standing, and he was actually way lesser. His pelvic range was only 9 degrees, and this is someone who is sitting all day long in a posterior tilt in his end range maximum available, and he spends most of his day sitting like this, and he wonders why he has pain. And when I showed him the result, he was like, so what do you want me to do again? And I said, I need you to move. And he's like, from where? And so I had to I had to do compression on his on his pelvis. I had to, then I put him on the live training and I said, can you just try and stand on one leg and see what these balls do? And he just had no concept of moving these balls around. And so you can see his standing is 7 and his sitting is 9. I mean, most people go up a lot. And if you see his standing pelvic, the thing you were saying earlier, Shauna, that his blue line is way back. So
Yeah, there. Can you guys see that?
Yeah, we can see it.
so really he's really in that posterior tilt. So if this is someone who's running 5 miles a day, then squatting, then doing all these things, and you have a clean MRI report where thankfully he doesn't have any discs screaming out. This is someone he's like, I can't, his doctor's like, your report's fine, there's nothing I can do, go to physical therapy. So we looked at his sleeping posture, and because that was where I started with, because I wanted to use the tactile input from the the couch where I mean treatment table, and you can see when he sleeps his ASIS doesn't even, on his belly, doesn't even touch the ground. He's like bored, like high up in the air. And so we started to fill up all the gaps between the bed and his lumbar spine, his pelvis. And then he understood what resting was, and then he was able to relax into it. So
Oh,
he's off to
excellent.
right now. So the goal was just so he could sleep on vacation and sit on the flight. So I haven't done much yet. I still have to monitor him, but he just found it really useful to know how much activity he's using while he's asleep to keep himself upright, or even in sleeping he's working out. So
Yeah, excellent.
that,
I think this extension
yes,
patterning is just this is so nice to show patients because you can see that the gray line and the yellow line are the same, which means it was like a board. His
yes,
back just his back and pelvis moved all at the same time. So
right,
and then it's jagged. You can tell there's some neuromuscular control issues if he's not having pain. So yeah, that's excellent. It's a great example. So we'll be
yeah,
curious to hear how he comes out. You can retest him and share it with us next time.
okay. But yeah, he was really, I mean, from all the cases we've seen, this is by far just where there was no mobility.
Yeah, and I'll kind of tag on and give you guys another. I know we're getting to the end of the hour, but just along those lines of looking at where he was in sit, his pelvic range was less than in stand, um, and that's another thing that you can use the test for. So, for example, if you have a younger client who has a spondy, so when they're standing and they're doing anterior posterior pelvic tilt and they're loaded and stand, right?
Right.
And they might not like going into extension, so you'll see like a reduction in their anterior pelvic tilt, and this is something that I saw a specific example of where the guy had no anterior tilt in stand range of motion, and when he sat, his pelvic range was great. So this told me, okay, at the time he hadn't had a diagnosis yet, but I'm thinking this guy's got a spondy because when he's loaded and he's standing, he won't move. And when he's sitting in flexion, now we can see that he has the range in his pelvis, but he's just not doing it when he's standing, probably because of guarding, if that makes any sense. So that's just another example of how you can use this, and then test and retest. You know, do your intervention, and then retest and share it with the client, share it with your physician referrals.